Hello, my name's Rob Ferguson and I'm the head of therapies at King Edward VII Hospital. I'm just having a look. I'd just like to say thank you to everyone that's very excited about this webinar in particular, and the panelists that we've got to speak. We've got a slight running order, which I've got sitting just over to my right-hand side. So if you'll excuse me if I sort of glance over in that direction every now and then. Just a little bit about King Edward VII Hospital. King Edward VII is a privately run hospital that is in Marylebone in London. We cover a number of different surgical specialities, orthopaedics being one, gynecology, breast surgery and general medical surgery. But today, obviously, what we're going to be focusing on is arthritis. And the reason why I'm really excited about this one is because out of all the pathologies that we end up speaking about, this is the one, especially from my point of view, from a therapy point of view, that pretty much everybody who's here on the webinar today is going to come across or be familiar with, whether it's actually been affecting them directly or whether they know that somebody in their family or a relation or a friend that's actually suffering from it. And at some point in our lives, it is going to touch us in one way or another. So, it is very, very important subject. So what we're going to do is we're basically going to have an introduction of the panelists. The panelists are going to speak for a short period on the subject of arthritis, and then we'll have a Q&A session at the end. If you have a look down at the bottom of your Zoom screen, you should see a little area there that has Q&A next to it. Please, if you do want to ask a question, just click on there, type your question in, and then what we'll do is we'll start to address as many as we can, depending on how many we get submitted by the end of the session. So I just want to introduce the panelists that we have in front of us now. I'm going to start off with Professor David Reid. Professor Reid is a highly experienced rheumatology consultant at King Edward's with over 30 years experience providing specialist osteoporosis services, and has actually published over 350 peer-reviewed papers. Next up, we have Dr. David Porter. Dr. Porter, a highly sought after senior football and sports medicine physician, and has been working at the forefront of musculoskeletal disease and ways of combating and treating those diseases, and was also previously the club doctor for Chelsea Football Club as well. Next, we have Mr. Luke Jones. Mr. Jones is one of the consultant knee surgeons at King Edward VII Hospital, and he's got extensive experience of dealing with arthritis, the optional timing for joint replacements, including partial knee replacements and minimally invasive knee replacements. So looking at it not just from a preventative measure, but also from a surgical point of view as well. And next we have Mr. Desmond Runganga. So Desmond is one of the clinical nurse specialists for orthopaedics at King Edward VII Hospital. Desmond, again, also has extensive experience with dealing with patients both pre-operatively and also post-operatively during their care pathway. And his experience is specifically important with what happens to you when you're in hospital, the preventive measures before, but what happens when you're in hospital, but also all of the follow-up that happens afterwards. And Desmond will even, be talking to patients 6 months after their surgery, checking in on them and making sure that their recovery from that surgery is as optimal as possible. So I think without further ado, I think probably we'll just get onto the panelists. So if I could just hand over to Professor Reid to have a chat with you about osteoarthritis.
Thank you very much, Rob, and welcome everybody, and thank you very much for logging in to this seminar or talk. I'm not actually going to talk specifically about osteoarthritis, but what I thought I would do is just to talk generally about what arthritis is. And first of all, to say that not everybody who gets a pain in a joint has arthritis. Arthritis means that there's inflammation in the joint. By definition, most people with arthritis, almost all, will have joint pain or arthralgia, but not all people with arthralgia have arthritis. So the name arthritis means that there is a degree of inflammation in the joint, whether it be in many joints or just in the one. You can split the types of arthritis into two very distinct varieties. There's really only one in the second type. So there's basically an inflammatory arthritis. The commonest of inflammatory arthritis condition, or chronic, is rheumatoid arthritis, but there are many, many other varieties of inflammatory arthritis. The second type of arthritis is what one might describe as degenerative arthritis, which is basically osteoarthritis itself. In osteoarthritis, pathologically, there is a degree of inflammation in the lining of the joints. That means that the lining of the joint is inflamed a little bit and produces, for example, excess fluid. But most of the time, it's relatively minor inflammation. Whereas in inflammatory arthritis like rheumatoid arthritis, the pain is caused by the persistent and marked inflammation within that joint itself. There's a different pattern of pain that you get with the two general types of arthritis. Inflammation arthritis tends to be painful and associated with stiffness, which is worst after inactivity. And particularly the stiffness will be noted, which can be quite prolonged when the patient wakes up in the morning. But it will also recur later in the day when they sit and stop doing activity. Osteoarthritis, on the other hand, is sometimes associated with a very little bit of stiffness in the morning, but it only lasts just a few minutes and then it's gone. But as the patient walks around or uses the joint, on the whole, the pain increases. And whereas in rheumatoid arthritis, it may, at least in the early stages, decrease on the movement of that. So when people are referred to a rheumatologist with joint swelling or joint symptoms, particularly where there is joint swelling, then we are going to try and initially divide them into, is this a wear and tear arthritis, a degenerative arthritis, osteoarthritis, or is it one of the variety of inflammatory arthritis? Now, the reason why it's important from the patient's perspective to make that distinction quite early on is that the treatment of the two varies very considerably. So we're going to hear more in the next few minutes about how you might prevent the pain of osteoarthritis and prevent the disability, and that's very critical. When people are defined as having a chronic inflammatory arthritis like rheumatoid arthritis, however, they are and should be managed with a variety of drugs. And it's a sort of panoply of different drugs that are, and starting with the very simplest and moving on to a more intense treatment, which suppresses the inflammation in the joint. And the symptom, the pain that is experienced by the patient is diminished by getting that inflammation under control. Local inflammation can be treated locally, but general joint inflammation, where lots of joints are involved, requires drugs, initially just anti-inflammatory drugs, but then building up to what are called disease-modifying drugs, and then in the latter stages, biologic drugs. And just finishing off in the next couple of seconds, it is a huge, there is an enormous difference in managing inflammatory arthritis now from when I started in being rheumatology. We now can prevent the disability that occurs with the inflammatory arthritis and prevent people getting into defined position, and often prevent them having to have orthopaedic surgery in the future if you get onto specific treatment early enough. So thank you for allowing me to speak.
Lovely. Thank you very much, Professor Reid. So what I'm going to do now is hand over to Dr. David Porter.
Hi, everyone. Thank you very much for logging in this evening to the webinar and for the opportunity to speak. Thank you very much, Professor Reid, for the summary to begin with. So I've been asked to talk this evening about preventative measures using exercise, and also using exercise as a management tool in the treatment of osteoarthritis. And I suppose that's a little bit due to my background in sport rather than my own physical capabilities. As we all know, osteoarthritis is one of the commonest forms of arthritis. It affects the hips, the knees, the spine, the hands, the wrists, ankles, and anywhere other joint that you can think of. Most people present to us with pain as the first symptom, and realistically a reduced quality of life. The first question would be, who gets osteoarthritis? Well, there's a huge range of people, and I'm sure everyone on this panel would tell you that we see people in their 20s all the way through into their 90s in clinic. And for the treatment of osteoarthritis, one of the most useful tools is actually exercise, but it's also one of the most controversial as well. So over the last couple of years, there have been a number of fantastic studies that have actually shown that exercise itself can be comparable to the use of non-steroidal anti-inflammatory drugs in the treatment of arthritis. There is a multifactorial side to exercise in the treatment of osteoarthritis. And basically, you have to think of it a little bit as a bespoke tool. There is no one size fits all for prescribing exercise for people with the diagnosis of osteoarthritis. What I tend to do is I tend to tell people to perform the exercise or the sport that they enjoy, as that's the way you get the best compliance and the most adherence to this treatment modality. What I would say is that as it is a bespoke treatment, not one that we can give a PDF for and expect everyone to follow a particular pattern, there is also adaptations that need to be made on an individual basis. So when I see anyone, I tend to concentrate on what they enjoy the most, what sort of sports they're actually able to do. And it is a difficult conversation a lot of the time, because most people who wake up with pain every day, most people with a diagnosis of osteoarthritis, the last thing on their mind is actually planning an exercise schedule into their week. But actually what we know is that if they can actually start exercising, they can decrease their pain levels quite substantially. And they do that in a number of different ways. So osteoarthritis and exercise, those people that suffer from it, if we exercise, what we can do is we can increase the strength and the flexibility of our muscles around the joints. We can improve the range of movement of the joints themselves. We can improve someone's mobility, reduce the joint stiffness, preserve bone density, and improve their energy levels. And all of this ties in with one thing in particular, maintaining someone's body weight. So one of the other huge factors in the chronology and prognosis of osteoarthritis is being able to control someone's weight. So what we find is that if someone has what's known as a BMI, a body mass index greater than 30, they're about 6 or 7 times more likely to develop knee or osteoarthritis compared to someone with a BMI of less than 25, for example. So if you can actually decrease your BMI through exercise, you can reduce the amount of pain that you're in, not only by strengthening the muscles that support the joints, increasing the mobility and reducing the stiffness, but actually by reducing your weight and decreasing the mechanical forces going through the joints. Now, weight loss doesn't just have a mechanical factor in the treatment of osteoarthritis, but actually it also has a molecular side to it as well. So as we gain weight, what tends to happen is that fat tissue can release inflammatory mediators into the bloodstream that actually promote joint destruction. So as you can probably tell, if we can reduce the weight, reduce the amount of fat tissue that we hold, we can actually reduce the amount of inflammatory mediators that attack our joints. So exercise has this multifactorial sort of perspective to it, of being able to strengthen the joint, being able to increase the mobility, reduce the stiffness, but at the same time reduce the mechanical load on a joint, and also reduce the molecular inflammatory response that goes on in the background as well.
That's great, lovely. Thank you very much for that, David. So I'm just going to hand over now to Mr. Luke Jones.
Great, thanks ever so much, Rob. And I think this webinar is a really good example of the reason patients get such great care at King Edward VII. A really joined up panel here, all pulling in the same direction. So I think what we've heard there from Professor Reid and Dr. Porter is exactly right. The first line here is getting your diagnosis absolutely right, and then using all the possible conservative measures that we can to stay on top of your pain, to get you functioning as well as you possibly can. And one of the things that is often the thought is that you come to see an orthopedic surgeon, that the first thing they want to do is do an operation on you, but I can assure you that's certainly not the case. And as Professor Reid in particular knows, there will often be patients coming from my clinic into his as we look to preserve the joint for as long as possible. Indeed, that was the entire interest of my PhD, trying to work out how to avoid doing operations on people. But at some point, despite the expertise of Professor Reid and Dr. Porter, people do find that conservative measures or non-operative measures have stopped controlling their pain. And at that stage, we do start to think, well, should we think about some sort of more definitive procedure or joint replacement procedure, particularly focused around the knee? And there are really four factors that I look at when I'm trying to make a decision about whether somebody should think about surgery. And these are you able to walk a mile without pain stopping you? Does the pain ever wake you up at night time? Does it stop you from doing the things that you have to do? You have to do your shopping, you have to look after your home, you have to look after your pets. And does it stop you from doing the things that you want to do? So can you continue to play tennis? Can you do 18 holes of golf? Can you do the things that you enjoy? And if you can't do these things, and despite the best efforts of the other techniques, we still aren't able to control those things, then we can think about more definitive procedures. And broadly, when we talk about surgery, particularly around the knee, there's three main things we talk about. Realignment procedures, where we try and move the weight from an affected part of the joint to a non-affected part of the joint. Partial joint replacements, where only one half of the joint is replaced. And then total joint replacements. And certainly a few years ago, and maybe when I was at medical school, there was a lot of anxiety about joint replacements, mainly related to how long they would survive. And that was because of the techniques that we used to put them in, the materials that the implants were made of, and in particular, the plastic shock absorber bearings that were put between the two. But the nature of joint replacements now is that 80% of joint replacements are in place and functioning extremely well at 20 years after insertion. And so people really now, if they come to the, if their joint replacement is put in appropriately at the right time, with a good technique, can expect a fantastic result from joint replacement surgery. And one of the things that I'm often asked by people is, how bad should I wait for my knee to be before I consider surgery? And certainly in the old days, the answer would be, well, you've got to be really disabled by your pain. But what we do know now, and really alluding to what David's suggesting there, is that what we want is for people to be healthy and active throughout their 50s, 60s, 70s, and 80s. And we know the joint replacements certainly have a ceiling effect to how much they can improve you. So the days of waiting until you're extremely disabled by knee pain before you have what is often a curative solution, are really over. And so I think that the important thing here is to engage with, firstly, your primary care, your GP physicians, and then certainly with the sports medicine and rheumatology doctors. And then when the time comes to make the decision to get back to your active, fit lifestyle. And certainly plenty of my patients back skiing, playing doubles tennis, back on the golf course, certainly riding their bicycles as far and as competitive as they want to. So I think the key thing here is to firstly do everything you can to optimize your health and your joint health in particular, and then to make an early definitive decision to get you back to your best.
That's great, lovely. Thank you very much, Luke. And I'm going to hand you over. That kind of goes really nicely into Desmond, our clinical nurse specialist, who's going to have a chat with you now.
Thank you very much, Rob, and thank you everyone for joining us this evening. I've been asked to talk about recovery techniques after surgery. And I'll talk a bit about recovery techniques and concentrate mostly on physio, pain management, nutrition, and mental or emotional wellness. Now, it is known that recovery actually starts before surgery by making sure that the patient understands what they're going to have done and having a rehabilitation and recovery plan in place. Now, this makes a huge difference. It has been shown that it helps reduce patients' anxiety levels prior to surgery, and this can help in making recovery easier and quicker. Here, King Edward VII used a process called enhanced recovery after surgery, also known as ERAS. Now, this is designed to make sure that the patients have the best possible outcome after surgery. Now, the key characteristics of ERAS are that it is evidence-based, it is patient-centered, meaning that the patient is involved in his or her own preparation and recovery. It is also designed to reduce patient stress response to surgery. Now, I won't go much into detail about it, but I'll quickly break down the key components that will help in recovery after surgery. So before a patient comes in for surgery, they'll undergo what is known as pre-rehab. So pre-rehab for short. This is an exercise program that is designed to prepare a person physically and mentally for surgery, to optimize the chances for successful outcome and quick recovery. So generally, the more fit and active you are going into surgery, the more likely you are to retain that high level of function after surgery and rehab more quickly. We have a very good team of MSK trained physiotherapists, occupational therapists, and nurses here at King Edward VII. I will sit down with you and create an individualized program for you to get ready for surgery. Now, in terms of physiotherapy, physical therapy is very important, especially after surgery. Not only can it help you heal faster, improve your flexibility and range of motion, it can also help patients manage pain levels without excessive use of strong painkillers. Now, following surgery, bones, muscles, and soft tissues undergo a period of healing. And failure to use that joint may cause it to heal improperly. And that can limit your range of motion, flexibility, and function of the joint, and the overall surgical outcome. And the good team here at King Edward VII, we create a specific rehab plan for you, and we'll guide you throughout that recovery program. Other thing is pain management. That is a very extremely important part of the recovery process. Now, we educate our patients prior to their surgery regarding pain, discomfort, medication, and other pain management techniques. Efficient use of these techniques can make for such a smoother recovery. Pain management will help you reduce stress and tension, help your body heal, help you move better. If you feel less pain, you can start moving and walking around as soon as possible. Now, we also recommend the classic rest, ice, elevate, and medicate approach to pain management. And I often come across many patients who have phobias about getting addicted to pain medications. And this can ruin their recovery if they're not taking the medications as they should. Now, we sit down with every patient and create an individualized plan for them so that they optimize pain management. The other thing I'll touch about is nutrition. A healthy, balanced diet is key to recovery. Eating healthy and drinking is important to your overall health. But after surgery, the body has to heal. So a varied diet plays a vital importance in the healing process. And we recommend a balanced diet that contains all the nutrients like proteins, fats, carbohydrates, vitamins, and minerals. One less physiologically, yet equally important aspect of recovery is the patient's emotional health. A condition often known as postal blues is very common and often accompanied by despair that no progress is being made. The postal blues can be a reaction to a number of things like general anesthetic, pain, lack of mobility, and increased dependence on others. In most cases, the blues will lift as you recover and resume normal activities. Having a positive attitude and a solid support network with friends, family, and patient groups will do you wonders to help come through that process. Things like going out during the day, enjoying the fresh air, a bit of sunshine when we're lucky to have some, listening to music, resuming hobbies and activities as soon as you're able to will help you overcome post-op blues. Now, in summary, people are all different, and as are the approaches to recovery and rehab. The key is to find what works for you. And the most critical thing about any operation is what you put around it. So your pre-rehab, your help in recovery, having access to people to advise you. Because no matter how much you read and how much you try and learn, there'll be things that happen in the period after surgery that you don't expect and you don't have a benchmark for. And this is where we come in. So the team here at King Edward VII is highly trained and very experienced in curating a personalized, patient-centered care plan and guiding you throughout the whole recovery process. Thank you.
Desmond, thanks very much for that information. And just before we go to the Q&As, I think probably the people listening will notice that the representative journey that you've gone through with each speaker, from diagnosis through to surgery and then even beyond surgery. And I think one of the really encouraging things that I see through the therapy side of things is that, as you've heard, there are a lot of options at every single stage of your pathology. There are a lot of options, but the main important thing is that you need a good team guiding you. You need a guide to take you through that patient care pathway. And I think that's really important to keep you on track and to make sure that you're optimizing your recovery right from the moment that you get your diagnosis right up until you reach a satisfactory conclusion for that episode of care. What I'd like to do is I'd like to just thank the panelists just for the information they've given. I think you probably agree. It's really useful information that you can take away and have a think about and possibly do some further reading on. I've got some questions. There's quite a few questions up here. So what I'm going to do is I'm just going to start from the top and work my way down. There's a couple of slightly longer ones that I'm going to go through first, which are more like case studies. So the first one is from one of our guests. She says, I've been unable to walk properly for the last 7 months due to an extremely painful swollen knee. I've had an MRI and told I have thickened synovial lining. I have had a course of oral steroids which reduce swelling, but not totally. What can be done to treat this? And I'd actually open that up to the panelists. Is anyone wants to raise their hand and jump in with regard to that question?
So I could start, but I mean, basically, obviously, Luke is the expert on knees. But I mean, first of all, it's everybody that has knee arthritis will probably have some synovial swelling or inflammation. Even if it's osteoarthritis, there will be some on an MRI scan. The question is the degree of swelling of the synovium, that is the lining of the joint. If it's very severe, then it could well be in one joint, just inflammatory arthritis. 7 months is a long time for say a reactive arthritis to last, but untreated. But for me, it would be important once you've excluded other types of arthritis, and that if there was really good going inflammation within the joint, then for me, all I'd be doing is injecting the joint with steroids initially and see whether it goes away. Because if it's an inflammatory arthritis, it should diminish very dramatically. Take the fluid off first, any fluid that's there, and then have the knee injected with steroids with a decent dose of a depot steroid preparation. It should settle down. It may recur because the depot steroid wears off after 4 to 6 weeks, and it may recur, but that's the first stage in management.
That's great, lovely. Thank you very much for that. I've got a specific question for Dr. Porter. So the guest asks, he says, is there a limit beyond which exercise is no longer effective? I am finding that cycling is becoming less effective at deferring knee pain. Should I increase activity or change in some other way?
Thanks very much for the question. I would say this goes a little bit to both my realm of sports medicine, but also into Luke's realm in orthopedics as well at the King Edward, because obviously there will become a point when pain is too much to bear and it is affecting your quality of life to such a large degree that actually an operative route might be the only sensible one for you. But as Luke said, there are lots of things that you should be doing in the meantime to optimize your own health. And when I say optimize health, what I would mean by that is actually optimize your own physical health. So as Desmond talked about, making sure that your nutrition is good, and as Luke talked about, making sure that you're taking all the right joint supplements, that would be the first sort of step. You should also start thinking a little bit about your cycling as well. How often are you cycling? Are you cycling too much? Are you giving yourself a recovery day? Is the bike the right bike for you? Is the saddle at the right height? You know, there are lots of different factors to think about here. And also, I tend to see quite a lot of cyclists who come with exactly this problem. And they're obviously, most of them are very, very keen sportsmen and women. And they don't just cycle, but they tend to have a gym-based program as well. And maybe it's a little bit about adapting what they do so that they're not putting just so much load through their knees, in particular in this case, but also thinking about introducing recovery days into their weekly routine and actually getting people to think like elite athletes is actually quite difficult, because elite athletes will always have a periodized plan to their training. They will always have recovery built in. And a lot of us who aren't elite athletes, we tend to train in a very different, non-disciplined way, where we actually are trying to find as much time as possible for our passions. And in this case, maybe cycling, where we're actually not maybe looking after our joints by pursuing those passions on a daily basis. And I wouldn't say the first instance would maybe to have an operation, and I'm sure Luke would agree with me. Maybe it would be to look at some of the factors around your cycling, some of the factors around what other training you do, and some of the factors around how you recover after you cycle as well. But I'll bow to Luke's operative knowledge as well.
No, I think you're absolutely right there, David. I think that's absolutely right. That activity modification and being sensible about expectations as well is extremely important, and I agree with you completely about that.
Great, lovely, thank you. I've actually got one which I probably will direct to Luke to see whether he's got any advice on the couple of points raised in this one. I've been suffering with bursitis, sometimes light and sometimes acute flare-up on knee, shoulder and hips. At one occasion, the pain started around 5 p.m. and by 9 p.m. I couldn't walk and ended up in A&E. But the only treatment I've been prescribed is naproxen. I really worry that one day this will become much worse. However, my GP doesn't seem to feel that I need a specialist referral. How do I get a specialist assessment when I live in London? So I suppose there's a couple of things around the condition, but also the pathway to actually come and see somebody. If you'd be happy to maybe look at that one, Luke.
Yeah, well, I'm sorry to hear about that. Sounds horrible for you. I mean, I think as you'll see Professor Reid nodding in the background there, these sort of, I think when you have bursitis and flare-ups in multiple joints, very often in these scenarios, I think that a rheumatologist is the first place, a port of call, and certainly that's certainly what I would suggest in that instance. And Rob, as you know, there is so accessing private care and see Professor Reid via the other it's actually very easy, isn't it, via the appointment line? But I don't know what your thoughts are on that, Professor Reid, but certainly that's the sort of thing that I would be looking to discuss with my expert rheumatology colleagues in the first instance.
I agree. It's always very difficult to answer these sort of questions in diagnostic terms by just on the information that somebody gives, because part of the critical part of making the diagnosis is actually also the examination of the joint. And it's been why during COVID it's been particularly challenging to try and diagnose people with inflammatory or other types of arthritis, because you couldn't see them physically face to face. Unfortunately, now at King Edward VII and many other places, we can see patients face to face, and that's a very critical part of making the assessment. So I think you know, it does sound, if multiple joints are affected, it does sound, or multiple areas of bursitis, you know, that could relate to what's called a seronegative spondyloarthropathy, which is the commonest type of which is ankylosing spondylitis. But there are a number of different types, including one variety of psoriatic arthritis. I saw that one of the questioners was questioned the question about psoriatic arthritis, which is a type of inflammatory arthritis. So a full diagnosis is necessary, and that does require, as Luke says, a rheumatologist to look at it, or it helps if perhaps a rheumatologist makes that diagnosis and gets some blood tests to confirm.
Lovely, thank you. We spoke about nutrition earlier on, and I've had a question here, and the guest asked, are there any important do's and don'ts with regards to diet and nutrition in terms of food we should eat or avoid to support healthy joints and calm osteoarthritis? I don't know whether I could open that one up to Desmond initially.
I think the key is just having a well-balanced diet, to be honest, and that makes a huge difference in everyday life. I'm not sure what Prof. Reid, if there's any specific foods that people should avoid, but I think just a healthy, balanced diet should make a difference.
Yeah, I agree, Desmond. That's I don't think there is anything to avoid. I mean, anti-inflammatory diets, if you like, are not always, not very often effective in relieving discomfort and pain. But you know, a Mediterranean diet with fish and chicken and lots of olive oil rather than animal fats is less inflammatory in terms of how the body deals with the dietary material than it is if you take lots of red meat and lots of cholesterol or high fat foods. So trying to avoid that. If the odd patient, and the management of this is very, I don't mean odd in particular, I mean just unusual. I know a few patients who do say, every time I eat a bit of chocolate, my knee swells up. Well, maybe they do have a true food allergy, but the obvious answer to how to deal with that is don't take any chocolate. You know, it's quite straightforward. So that managing that's very easy.
That's lovely. Thank you.
I'd find that one quite difficult.
Sorry. Yeah, me too.
I find that one quite difficult, to be fair, Prof.
It'd be worse if it was red wine, but there you are.
I've got another question on this similar thing. What joint supplements would you recommend to anyone, if any?
I'll start if you want. It's difficult. There are lots of supplements out there that are recommended to people. There is not a lot of evidence, and my panel colleagues can correct me if I'm wrong. There's not a lot of evidence that any of them are definitively actually helping someone with osteoarthritis. I personally see a lot of people who find that glucosamine and chondroitin supplementation does actually help them. It doesn't help in the short term, but they tend to find it helps over a longer period of time. They certainly feel that their joints are more lubricated, and they don't feel as if there is as much, as they put it, friction as they actually pursue their desired sports. But as I said, there aren't really any particular supplements that have been shown to be definitively helpful for osteoarthritis.
That's lovely, thank you. There's a question here which leads into something that we maybe haven't touched on, which is things like functional bracing. The person writes, I've been diagnosed with osteoarthritis on the left side of the knee and play active double tennis, walking and yoga. I've been given a uniloader brace, but find my calf stiffens up and not sure if helping or if it's helping or not, and would you recommend this? I think maybe that answers things about like a wider question of functional bracing, kind of like pre and
Yeah, no, I'm happy to speak to that. I mean, I think you're probably referring to the OSSA unloader brace, and those braces can be very effective for people when they have arthritis, particularly confined to one compartment of their knee. And what it does is it realigns the joint by pushing on the bones, so the weight goes through the unaffected part of the joint, and that can be helpful. But as you might imagine, the consequence of that is that it's pushing pretty hard on the soft tissues and the bones around the joint, and they can be a little bit uncomfortable because of that. I think if you're getting to the stage where, despite bracing and all the other measures that we've discussed, you're still finding it difficult to do your normal sports, then that's the sort of time that I would be looking that we could certainly discuss or consider other interventions. And again, it comes back to the same story, that if you've got partial joint replacement, patients playing plenty of tennis, plenty of golf, plenty of skiing, plenty of bicycling, and really what we're looking to do here is keep you in great shape. And one of the things you mustn't do is wait until you can't exercise for a year because your knee pain's so bad, because then you're going to find that your recovery from your joint replacement is so much more difficult, as Desmond alludes to.
Lovely, thank you. Sorry, I lost my mouse pointer at that point. It disappeared between screens at some point there. There was another one. I'm just going to scroll up and find it up here. So people with other pathologies in the background, there's a couple of people asking about how other pathologies will be having any secondary effects on their conditions. So I've been diagnosed with osteoarthritis in both hips, but I also have ulcerative colitis. I have pain in most of my joints every day. Should I be asking for an MRI to check if my other joints are affected by osteoarthritis rather than arthralgia?
You want me to have a go at that? So the ulcerative colitis and other inflammatory bowel diseases, particularly Crohn's disease, can be associated with arthritis, and they are associated with inflammation arthritis, and they're associated with two different types. One is an arthritis which tends to be troublesome at the same time as the bowel is. So when the bowel condition settles down, so does the arthritis. And the second type is one that continues without relationship to the arthritis. And the second type usually has as part of it sacroiliitis, which is inflammation in the joints at the bottom of the spine, where they attach between the spine and the pelvis. And you can detect that on an MRI scan for sure. But you know, common things are common. Depends obviously in the age of the person, but it's not at all unlikely that you can have both inflammatory bowel disease, ulcerative colitis, and osteoarthritis of your hips, and so it doesn't. They're not necessarily connected.
Lovely, thank you. There's a few people asking questions about psoriatic arthritis. I'm just going to kind of go through them. One person is saying, could we just mention psoriatic arthritis? And there was another one down here. I'm just trying to find, there's some really good questions coming through. Oh, I've lost it there. So yeah, I think it was, one of them was just talking about whether we could just mention about reactive and psoriatic arthritis, and also whether what the long-term prognosis was for these types of arthritis.
Dear, I guess that's me again. Sorry about this, holding the questions. So psoriatic arthritis is probably the second most common type of chronic inflammatory arthritis after rheumatoid arthritis, probably. Confusingly, there are 5 different varieties of psoriatic arthritis that are described, one of which is involves the spine that I just talked about, sacroiliitis. So that's one of the types. The commonest type is where the joints are affected in the same sort of way as rheumatoid arthritis, except one of the classical things about psoriatic arthritis is that the joints at the ends of the fingers are affected, whereas in rheumatoid arthritis, it's the joints in the middle of the fingers that are most affected. Psoriatic arthritis also tends to be rather less symmetrical. So in other words, in rheumatoid arthritis, the symptoms at least tend to match from one side of the body to the other, say both hands, the same areas in both hands at the same time, whereas psoriatic arthritis can affect a patchier thing. In terms of management of the different types, they're not that dissimilar to rheumatoid arthritis, at least in the early stages. They're very similar. So you go on a sort of journey of simple anti-inflammatory drugs like naproxen or ibuprofen, probably naproxen better than ibuprofen, simply because it's longer acting. Then you develop, go through disease-modifying drugs, and I know that one of the questioners asked about methotrexate, and methotrexate is probably one of the commonest of the disease-modifying drugs, particularly useful in psoriatic arthritis because it has an effect on the skin as well as the joints. And then you go into the newer therapies with the biologic drugs, of which, and then that circumstance, when patients get down to that level of management requiring those sort of drugs, and then there are slightly different biologic drugs that work in psoriatic arthritis than from the ones that work in rheumatoid arthritis. And it's a sort of, it's important obviously to have the diagnosis right and then to choose the correct drug. And that does require a specialist service. On the whole, these sort of biologic drugs and even disease-modifying drugs are best managed by a team approach. So you have nurses, physio, and on the whole, this is correct that in the private sector, that doesn't exist. So the team makes effort. So I must say that for most patients that I diagnosed with a chronic inflammatory arthritis, I will give them some initial advice and management, but then I'll say to them, really go back to your GP and get a referral to your local rheumatology service, who will give you the whole approach, physiotherapists, occupational therapists, nurse specialists who are giving biologic drugs, etc., and even pharmacists, all in the same team. And it would be nice to replicate that in the private sector, but it's a pretty expensive process.
Lovely, thank you. I had another question which links into what we were mentioning around about how important is it to be under the care of a consultant once you have your diagnosis? Maybe to Luke.
Yeah, well, I think what you really need is somebody who's an expert in the condition that you have, because then they can guide you to the appropriate people for your condition. So I think very often what people who come to my clinic, that how they've struggled is because even though they've had a diagnosis, nobody's been really there to coordinate their care effectively, and their care can become quite disjointed. And that's one of the great things I think at King Edward VII is that whichever team member that you're seeing in front of you here that you're under, everybody works together in that coordinated fashion. So what you want to be able to do is to be under the care of somebody who is able to access you all the other experts that you might need. So I think that coordinated care for me is really absolutely essential. I don't know what the others think about that.
I think from, I mean, again, just jumping in from a therapy's point of view, that MDT approach is really what I was alluding to. When I say MDT, I mean multidisciplinary team approach, which is part and parcel of the way that that we operate at King Edward's. It is really important because you do need guidance through that whole journey. And that's going to be multifactorial, and depending on what stage of that care pathway you're on, you'll have input from either 1, 2, or 3 medical professionals within that area. So I think probably to support what Luke was saying is that actually it's not just the consult. I think once you enter into that, it's important that you have this concerted effort from a number of different facets and other different professionals helping guide you through that care pathway, through the episode of care. effectively, and that's kind of what we're all here for, really, under that MDT. There was thank you, Luke, for that. There was another question here, which I think may be for Dr. Porter. It's on rheumatoid arthritis, but I think again, it just kind of around all types of arthritis about what you can do in the background. So they've had rheumatoid arthritis and have been told possibly fibromyalgia too. I'm on Imraldi injections, which have improved my life, but I pick up lots of infections now and I've had to stop having whilst on antibiotics. I was exercising, but now have a frozen shoulder. I've had one cortisone injection which didn't work, and I'm awaiting another ultrasound, and I feel like I'm not getting anywhere, which I think was alluding to maybe the psychological effects that long-term pathologies like this can have. What would you suggest would optimize recovery, or what options do you think that you would suggest, David?
Yeah, thank you very much for the question. I'm really sorry to hear that things have not been very good for you over the last little while. I would say that actually there are lots of options for you at the King Edward VII. There are lots of different practitioners that can potentially help you, all the way through from Professor Reid sitting on the panel through to Desmond and Luke, as well as myself. I think when you're talking about someone who has multiple different joints that are affected and wants to maintain a certain level of physical activity, what they need is what we've been talking about in the previous question, a little team behind them. And actually what we try to do at the King Edward is form a team around that patient in the same way that we would have formed a team around athletes in the professional sporting sector. And actually by doing that, what you can do is empower people to exercise the way they actually should be, to the heights that they can, make sure that they have the right nutrition in place, make sure that the right medication is in place as well, and make sure that they have the right avenue to people like Luke, so that there isn't hopelessness at the end of the tunnel and there is light instead. At the King Edward, we also have a performance psychologist, a professor of psychology by the name of Professor David Collins, who used to be the Olympic Team GB performance director. And from a psychological and mental health perspective, he is acutely and keenly aware of the difficulties some people with chronic pain go through. So I would also always recommend him to anyone that I see in this sort of situation. With regards, and just I don't want to waffle on too much, but with regards to your frozen shoulder, there are lots and lots of different avenues of treatment that are open to you, all the way through from conservative physiotherapy through injection therapies with steroids or platelet therapies. And it isn't a dark tunnel. There is definitely light at the end of the tunnel, and all of us routinely manage people with multiple joint pathologies. So please don't give up any hope.
Lovely, thank you, David. We've had quite a few questions on fatigue, and I think that definitely can come from a number of different angles, whether it's sort of like from pain, or medication or other things. So I'll read a couple of them. I have rheumatoid arthritis and my pain is managed fairly well with medication, but I often struggle with fatigue. Is there anything I can do with exercise or diet to help reduce this? And also, could you please cover fatigue that comes with arthritis? I have psoriatic arthritis and I'm finding fatigue the hardest part to deal with. I think also you can, with pain comes fatigue. As well. So even the people with osteoarthritis, if you've had that for a long time, would probably benefit from some advice dealing with that area.
I'll leap in, not because I can help to deal with fatigue, but because first of all, it is well recognized that with inflammatory conditions of various types, fatigue is a really major issue. And even as some of the questioners are implying, when the inflammation arthritis is being controlled, there's been some wonderful work by a guy, Neil Basu, who is now a professor in Glasgow, is a trainee with me. He did some really, really exciting work about vasculitis and inflammation in blood vessels. Which can be very serious. But even in people with chronic vasculitis, where you've controlled the vasculitis altogether, they're left with fatigue. And actually, you can see areas within the brain where it's not functioning correctly, and it's not there is a sort of fatigue center, if you like, where there is active management. Now, how to manage that? There isn't a drug. There isn't any drug that's available to manage it at all. But where treatment has been helpful, actually, as David Porter was saying, implying Professor Collins would be a really good person, because the psychological management of fatigue is probably the most, to my understanding, and others can correct me, but my understanding that is probably the most likely thing to help. Where there's various forms of psychological management, including talking therapies and others that really do help people with fatigue, as well as a graduated exercise program. David will maybe have more to say about that.
Thank you, Prof. I would say that one of the things to think about is what we touched on earlier, and all of us have mentioned it in some guise, is actually that element of recovery into our daily lives. And actually, one of the things that has been found, well, the only thing that has actually been found to be the most beneficial for an active recovery is sleep. And obviously that ties in very nicely with fatigue. And it's easy enough to say, please go and get 8 hours of sleep, but very hard to do for some people. What I would say is that it's about trying to plan your exercise, plan your daily routine so that you maximize your sleep as well. I see lots of people who get home from work, eat something, then go out and train in the evening and wonder why they can't sleep in the middle, at 11 o'clock, 12 o'clock at night. And there are lots of physiological reasons why that might be the case. And if they just switch their training to early morning, middle of the day, then actually they might be able to get sleep, and fatigue might not be such a big issue for them. Those people with osteoarthritis, psoriatic arthritis, or chronic pain in general, their fatigue might be something slightly different, and someone like Professor Collins would be fantastic to speak to.
That's great, lovely. I've got one for Luke. Why do most NHS consultants state that a person cannot have, and it's an example, a total knee replacement surgery because they are too young? What age would you say is too young?
Yeah, I obviously can't speak to anybody else's practice, but I think the answer behind this is that there is no age that's too young for joint replacement. The indications for joint replacement are really clear. You have to have the X-ray findings of bone-on-bone arthritis, and you have to have the symptoms that are affecting your life badly enough, despite all conservative measures. And as I was suggesting at the early talk, is that what you do not want to do is to spend your most productive years of your life in pain because you're worried about a potential revision 30, 40 years down the line. You know, if you spend your 40s and 50s not exercising, getting out of shape, not sleeping properly, arguing with your wife because you're grumpy every evening when you get home, your life's going to be pretty miserable. And I do see patients who have tried that approach. So I think we need to have a real, we have to look here at what the aim is. The aim is to get you back to your best. And there are plenty of ways to do that. But one of them certainly is joint replacement. And I'm certainly the youngest person I've done joint replacement on is 32. They're now delighted, back at work, being productive, supporting their family, and very happy. I think there has traditionally been an anxiety about operating on young people because of worries about them wearing the joint replacements out. That is not a concern anymore in an appropriately well-placed total knee replacement or indeed partial knee replacement.
That's lovely. Thank you. Thank you very much. Just got time for one last question. One area that we haven't touched on is can osteoarthritis in the spine hide the amount of osteoporosis present? And then there was another question, which is there any advice for severe OA in the lower spine? So I don't know whether maybe Prof. Reid might have something to say about that initially.
I'd love to speak about osteoarthritis and osteoporosis but not the rest. In terms of osteoporosis, theoretically, osteoporosis affects different group of people than osteoarthritis. So osteoporosis tends to affect small and aesthetically slim people, and as David Porter said earlier, osteoarthritis tends to affect the larger people with more weight on board. However, that doesn't work for the individual, and for an individual you can have both osteoporosis and osteoarthritis. One doesn't make the other worse, but it can be quite challenging sometimes to define, say, if somebody who's got osteoporosis and then has a lot of low back pain, whether the low back pain is due to fractures that have occurred due to osteoporosis, or whether it's due to degenerative change. And just finally and technically, when you're measuring osteoporosis risk by a bone density scanner, it's almost impossible when patients have osteoarthritis of the spine as well, because the bone density goes up, even though the bone itself it would be thin if you were to take it out and look at it under a microscope or measure it in another way. And that's just a technical issue with the scanner. You can't tell the difference about where the bone is, which bit of bone. You're just measuring bone.
And Dr. Porter, did you have any advice on things that could be done?
Lumbar spine. Yeah, I think the lumbar spine issue, and Prof has covered quite a lot of it already. One of the things that is known at the moment is that if you took a group of 120 to 30-year-olds and you put them through an MRI scanner, they will all have some form of osteoarthritis in their spine at various different levels. But what was interesting in that study is not one of them actually complained of any pain. So scans give us a picture, but they don't give us the whole picture. And I think we should always be quite cognizant of that. If someone has symptoms and signs of osteoarthritis and radiological evidence of it as well, then there are different treatment modalities that could be used. And again, working right through from physical therapy, from physiotherapy, core exercises, making sure that posture is right, making sure that they're using the right sort of chair at their desk, making sure that they're in the right sort of saddle and they're using the right sort of posture when they're cycling, all the way through to weight loss and all of the supplements that we've talked about this evening. All of those sort of things can be done and should actually make a difference.
That's great, lovely. Thank you very much. I think we're out of time for the questions, but I think we've covered a lot of areas there. And there's been some really amazingly useful advice from all of the panelists. Before we do sign off though, a recording of the webinar will be shared with all of the delegates, all of our guests that have attended today. More information about the panelists and the hospital can be found on the hospital website, which is www.kingedward7vii.co.uk. The hospital does offer payment plans to help spread the cost of treatment, but what I would say in regard to that is that starting a conversation is the most important thing, and actually talking to somebody. And I think if you are one of the guests on the delegate list today, or whether you know somebody who's suffering from symptoms that sound like they might be arthritis based, or they just want some advice, I think it's just really important that you actually start a conversation with somebody. And the easiest thing to do is just to call the hospital, speak to the bookings department, because the people that do man the phones there will be able to direct you to the right medical professional. But I think getting that conversation started is the first step. And as Desmond said, treatment for conditions such as osteoarthritis actually start with that initial conversation. That's where the treatment starts, where we start to kind of like take the veil off a bit of the mystery and get that information to help you recover. What I'd like to do is I'd like to thank Professor David Reid, I'd like to thank Dr. David Porter, Mr. Luke Jones, and Desmond Runganga for the expertise that they've brought to the panel, and the questions that they've answered. And it's been a really interesting webinar. So lovely. Thank you very much, everybody.
Thank you.
Thank you very much, Rob.